thanks so much for having me this morning. I wanted to share with you sort of a broad literature review that I embarked on in terms of looking at heart failure in dialysis patients. The reason that I did it is we are sort of planning and for projects for the year moving forward. So I wanted to have a good idea of the lay of the land prior to doing that. And then, interesting. Oh, yeah, there it is. In terms of getting started, I did want to say beforehand that there are a few pictures of sites from the Pacific Northwest sort of interspersed throughout the PowerPoint slide. I recognize that our days are getting shorter and darker, and so I just wanted to remind us that we still live in a beautiful place. And this, sorry, I think there was that's okay. But going ahead and sort of starting with the scope of the problem, and so thinking about heart failure and kidney disease, what does that look like in terms of the numbers? So sort of zooming out in terms of cardiovascular disease, it affects up to 60%, although in some studies that could be an underestimate of dialysis cohorts that were studied across places like Australia, New Zealand, and the US. Mortality rates in this group are about 14 per 100 person years, and that's 10 to 20-fold higher than age-matched controls, gender-matched controls. Cardiovascular disease is the primary cause of death in about 40% of dialysis patients. And when we come to heart failure, in Wave 2, the study, USRDS dialysis morbidity and mortality study, done in about 2005 in approximately 2,000 patients with incident dialysis, and they were looking at things like septicemia, bacteremia, and cardiovascular disease rates using admission claims data. And what they found is that the incidence of heart failure is about 71 per 1,000 person years. And folks with combined heart failure and ESKD, mortality rate is about 83% at the 3-year mark, so quite high. This next graph is from the 2021 USRDS data looking at the prevalence of common cardiovascular diseases, and I like it because it stratifies folks among the different dialysis modalities. So for heart failure, about 45% of folks on hemodialysis and 33% on PD have heart failure. And so across these two slides, what I was wanting to show is that there's high prevalence of heart failure in dialysis patients and that the stakes are really quite high. So it's important to sort of take a look at this issue further. The next part is sort of thinking about the determinants of heart failure and end-stage kidney disease. And I think before we start sort of looking at the relationship between the two, it's important to sort of remind ourselves of how we define heart failure. It's a syndrome of both mechanical and hormonal issues that result in signs and symptoms, as well as structural and functional cardiac abnormalities that present with symptoms related to stasis of blood and hypoperfusion of organs. And we think about heart failure in sort of two phenotypes, impaired contractility versus relaxation issues, so reduced versus preserved ejection fraction heart failure. And I intentionally didn't put sort of cutoff percentages because I think depending on what you're reading, which guideline, et cetera, the percentages can sort of fluctuate. And sort of narrowing in on the question of, are there kidney-specific risk factors associated with heart failure? There are the traditional risk factors that we think about, like age, male sex, hypertension, diabetes, et cetera. But in our dialysis patients specifically, volume overload is complicated in the context of their end-stage kidney disease. Things like electrolyte derangements, uremic toxins, et cetera, are also identified as sort of novel risk factors in this population. And I think what's interesting about this table is that, these are risk factors that are also implicated in sort of the progression of kidney disease to ESKD, loss of residual renal function as well. And so I like this chart or this sort of diagram from a paper from a couple of years ago that Nisha worked on. This diagram shows shared risk factors between the kidney and heart, as well as the kidney-specific risk factors that we talked about. And in the middle, they have sort of different categories wherein the bidirectional interplay between the heart and the kidney sort of comes to a head. And really, it's this bidirectionality and interplay that makes it difficult to sort of diagnose and treat heart failure in dialysis patients. And if we take a look at it on a cellular level, so it's a bit of a busy slide, I know, but I will sort of point out a couple of things here. This is looking at endothelial cells, and what we're seeing is that there have been noted associations between uremic toxins and increased reactive oxidative species, and that has sort of downstream effects in terms of increasing inflammation, which could lead to things like increased permeability of the blood vessels. There have also been mechanisms that have been outlined showing that there's inhibition of the nitric oxide synthase, and so decreasing the ability of blood vessels to vasodilate, as well as increasing risk of things like atherosclerosis. In kidney disease, derangements and acid-base disorders have also been associated with increased transcription of inflammatory markers such as NF-κB. And then metabolic acidosis have also sort of been associated with increased RAS and endothelial dysfunction, and so changing the dynamic of sodium avidity and volume overload in these patients. I bring up sort of all of this to say that there have been mechanisms proposed. I think there's some controversy in some of the pathways, but there have been mechanisms proposed that show that kidney disease can be implicated in things like endothelial dysfunction, as well as myocardial fibrosis and atherosclerosis. And there's quite a bit of work also showing that there's significant cardiac remodeling that we could pick up with clinical sort of testing as well in end-stage kidney disease. So work showing that about 75 to 90% of patients with ESKD having increased left ventricular size, so LVH. Not only that, but LVH progresses or is shown to progress in patients on dialysis. So Foley and company conducted a randomized controlled trial of about 600 patients with incident dialysis patients, and they looked at hemoglobin targets and associations with LV size in that context. And what they found is that left ventricular mass increased in about 62% of patients, and 49% of those patients developed overt heart failure. There's also work done in the CRIC cohort, which we could talk a little bit more about later. Nisha and a couple of folks showed that as patients transition from advanced CKD to end-stage kidney disease, they didn't know that there was change in left ventricular mass index within this specific population, but that ejection fraction did decrease. And so, we talked about sort of kidney-specific risk factors, but what about dialysis? What sort of risk factors are patients incurring in the context of being on dialysis? This diagram I like talks us through sort of in-center hemodialysis and risk factors that may be associated. And so sort of going from right to left, if you take a look at the first part, so volume overload, I think there's been a lot of conversation around the intermittent nature of in-center hemodialysis, sort of causing or resulting in sort of wide fluctuations in volume between patients from a day-to-day and maybe even over long interval weekends. And that sort of volume-related pressure and stress on the heart over time, obviously, will have negative effects. The second two sort of points talk about the variability of blood pressure in dialysis patients. There's ongoing studies looking at, which blood pressure measurements do we take to be associated with long-term sort of poor outcomes, intradialytic pre-post. And there's, quite dramatic fluctuations in blood pressures throughout the dialysis process, and that has been sort of associated with myocardial stunning and negative impacts on the heart in that context. The last point is that the group of sort of conditions that we think about as being associated with end-stage kidney disease, things like anemia, bone mineral metabolism issues, have also been implicated with long-term poor outcomes regarding heart failure. We'll go through a couple of them here. And so the normal hematocrit trial, which was in the 1990s, randomized about 1,200 hemodialysis patients with cardiovascular disease. And what they were looking at was sort of different hematocrit targets and their associations with mortality and I think that the trial actually had to be discontinued early as they saw that there was higher mortality rate in those folks in the higher hematocrit group. And really, in terms of anemia management in these dialysis patients, there aren't a ton of sort of studies and guidelines around sort of what are the targets in these dialysis patients that are optimal for sort of managing or preventing heart failure long-term. In the CRIC cohort, there have been a couple of studies looking at bicarb as well as FGF23. So there's a study that showed that increased bicarb in CRIC patients was associated with 66% increase in the relative risk of heart failure hospitalizations. And we know that alkalemia in our patients with alkalotic dialysates are issues quite often. And then in terms of FGF23, we think about it a lot in our world in association with things like phosphate and calcium, vitamin D, but it's a peptide that's also been associated with regulating myocardial growth and differentiation as well. And in CRIC, we showed that increasing FGF23 levels had some associations with de novo left ventricular hypertrophy. Parathyroid hormone levels and targets therein are quite a controversial topic, as we know. But there have been some experimental models showing that increased parathyroid hormone levels could be associated with myocardial fibrosis as well. And really the sort of big point of this trial is that, or this slide is that, there are quite a number of things that we have to manage in our dialysis patients that also have interplay with regards to cardiac outcomes, but the sort of targets and the studies around these management areas are quite undefined, I would say. Thinking about biomarkers, so we know that in our patients, given the sort of decreased renal clearance, BNP and troponin levels tend to be elevated, but the question is sort of what to make of those elevations. And so, there are changes in BNP and troponin levels peri-dialysis, so they decrease post-dialysis. And initially there were questions about, is that the effect of dialysis, or does that reflect changes in volume status of patients post-dialysis? And really the latter is sort of what's more accepted recently. The other issue is that there aren't really accepted cutoffs for BNP and troponin in our dialysis patients. And despite all of that, they have been shown across multiple studies to provide meaningful information regarding sort of prognosis. So elevated levels have been associated with significant increase in all-cause and cardiovascular mortality. So they are important. It's just hard to make sense of what levels we should pay attention to and how we should navigate that. So in summary of this, sort of the second section of the presentation, what we've learned is that kidney and dialysis specific risk factors exist for heart failure, and that left ventricular hypertrophy, relaxation that shows diastolic dysfunction is common in patients with combined heart failure and end-stage kidney disease, and that the overlap in clinical presentations between these two diseases and the fact that there's little guidance around sort of biomarker cutoffs as well as targets for therapies makes it difficult to diagnose and treat heart failure and in dialysis patients. All right. Well, we mentioned therapies, and so the next section is sort of about what therapies are available to us and how do we use them in this group of patients. So this is a diagram. It is really quite busy, but the next slide, I'll sort of focus on a couple of the areas that would be, I think, important and pertinent for us to talk about. But this is a diagram from a recent review article on managing heart failure patients in dialysis. And the point of the diagram is really to say that guideline-directed both medical and device-related interventions that have been shown to have mortality benefits in folks with heart failure with reduced ejection fraction really have not been studied in our patients. ESKD patients have been left out of a lot of the randomized controlled trials showing effects and benefits of these therapies. I will highlight 3 areas that do in fact have some randomized controlled trial data showing effects of these therapies in dialysis patients in the next couple of sort of slides here. The first one is beta blockers. There is a group out of Italy, I believe early 2001, which looked at the effect of carvedilol versus placebo in 114 patients on hemodialysis. And what they found is that there was reduced mortality in those patients on carvedilol, and improvements in ejection fraction as well at 6 and 12-month mark. The same group looked at tolmesartan versus placebo in 332 patients, and what they found there was that there was reduction in all-cause mortality as well as cardiovascular mortality, and as well as hospitalizations for congestive heart failure. One thing that they did note was that tolmesartan was a lot more likely compared to placebo to be discontinued, and the reasons given have to do with side effects, so hypotension and hyperkalemia. And this is sort of a point that I think is really important to make and to highlight, and that is that our dialysis patients tend to be less frequently on continuous goal-directed medical therapy in the setting of concern for side effects. MRAs are no different. So prescription rates for MRAs are about 33 to 45% in the ambulatory setting, and that's in the setting of oftentimes concern for hyperkalemia. There are two very small randomized controlled trials, one 16 patients and the other 18 patients on hemodialysis. And what they found is that spironolactone increased mean LVEF and decreased LV mass. And neither trial showed increased risk of hyperkalemia. But again, a lot of these trials are very small sample sizes. And then if you take a look at some of the issues with generalizability across the trials as well. I will say that it's an exciting time because there are a couple of randomized control trials in the pipeline. And so with regards to MRAs, I believe there are two studies, one called Achieve and the other called Alchemist, that are looking at the effect of aldosterone in patients on chronic hemodialysis. And then there is also a study looking at the effect of SGLT2 inhibition in dialysis patients on hemodialysis, both diabetics and non-diabetics, called DAPA HD. And I will say that these studies are not specific to heart failure patients, but they'll likely do like sub-analyses looking at those patients. And then there are 3 studies looking at Entresto in dialysis as well. So it's an exciting time. This last side of the section is an acknowledgement that I told you quite a bit about the sort of prevalence of diastology and HFpEF in heart failure patients on ESKD, but the guidance around sort of managing these patients with HFpEF is, I would say, even more sort of sparse than HFrEF patients. But the ACC generally, this is the sort of the general recommendation for management of HFpEF patients independent of dialysis. And so, one of the therapies that are available to us to treat heart failure patients is dialysis. And so my question then was about, are there sort of clear indications that one modality is better than the other? And so there are actually a couple of review articles that came out, Cochrane review articles that came out earlier this year. And one of them was looking at home versus in-center hemodialysis. And so they searched for randomized and non-randomized studies up to 2022, looking at home hemo compared to IHCD patients with outcomes like cardiovascular death, all-cause death, and left ventricular mass. And really, the highlight of the results is that it's uncertain whether home hemo is associated with improved outcomes. So I'll show you a couple of their plots here. So they took a look at, in terms of cardiovascular death, they took a look at over 30,000 patients, and the risk ratio was really not significant, as you can see here. And then with regards to all-cause death, that's over 58,000 participants that they considered across all the studies that they were looking at. And although it looks like the risk ratio is significant, what's important is the third circle below, which is that there's quite a bit of variability. So 84% variability is quite high amongst the studies. So this is sort of a very low confidence finding here. So Then the question of, is PD the answer in all of this? We talk about the fact that continuous UF, gradual fluid removal, and solute removal likely has less impact on hemodynamics in PD patients. And so is PD the way to go? But when you take a look at the studies that are out there about PD and heart failure, they tend to have pretty small sample sizes, be single center. And there are a couple of really interesting studies, particularly coming out of, I think, Spain, wherein PD was sort of looked at in patients with eGFRs less than 60 that were diuretic resistant, but not necessarily folks that met ESKD criteria. So not necessarily generalizable to the ESKD population. An important consideration in PD patients is sort of capturing residual function over time as well. And luckily, there's another review article from Cochrane that came out earlier this year that tries to assess sort of the benefits and harms of PD versus HD in people with kidney failure. And they looked at studies from 2000 to 2024. Their primary outcome was residual kidney function, and they had a number of secondary outcomes listed there, as you can see. And, of all the studies that they included, 2 were randomized, and then 82 not. And really, the punchline here is that PD had uncertain association with residual kidney function, as well as all-cause death and cardiovascular death. I will say that when they did restrict their search to just looking at those 2 randomized controlled trials that contained over 1,100 participants, there was some evidence that PD may reduce the risk of all-cause mortality. But when they took a look at the risk of congestive heart failure in PD patients compared to HD patients, that was also sort of uncertain evidence, not really conclusive. Why might that be? There's sort of a lot of literature out on sort of the benefits of PD early versus late. And so, as I mentioned earlier, with sort of gradual UF, does that mean that PD allows for sort of improved or like decreased reduction in residual kidney function earlier on, and therefore better control of volume status earlier on? But as they lose sort of their residual kidney functions, their peritoneal membranes change, does that sort of dynamic change as well? And otherwise, the risk factors that I talked about in terms of inflammation and oxidative stress and kidney failure also hold up in PDS, as they do in HD. And then glucose exposure, again, there's not a ton of conclusive work out there, but there is some sort of some folks who posit that there's increased prevalence of metabolic syndrome after initiation PD. And so all of that to say, in this section, the question of, is there a specific dialysis modality that is optimal to use in patients with heart failure? Don't think that has been answered. And so all of that work and sort of literature review led to the proposed work, which I'll very briefly share since we're close to time. But essentially the questions that came up is, it sounds like, the first part, I think there are some good indications that likely diastolic dysfunction is predominating in patients with ESKD. But my curiosity is, are those rates different based on dialysis modalities? Are the subtypes different based on dialysis modalities? And then do outcomes like all-cause and cardiovascular mortality, hospitalization differ by these subtypes in patients on dialysis? And so we will be taking a look at the CRIC cohort. I know that a lot of you have heard about it before, and you know this cohort well, but it's a prospective cohort of about 4,000 adults with eGFRs 20 to 70, recruited early 2000s, and not non-kidney transplant patients at the outset, and had echoes at different intervals. And what we'll do is sort of include patients who went on to develop end-stage kidney disease and did not have heart failure at their incident ESKD time point, and then look at rates of heart failure, subtypes of heart failure, and stratify by dialysis modalities to try to get at some of those questions that I mentioned above. All right. These are my references, and I want to thank you for having me this morning.
Thanks, Dr. Assefa, for wading into a topic about which there's plenty of strong opinions in this group. So I'm sure there'll be good questions. And with that, yeah, questions for Mahlet.
I have a question. This was a wonderful overview and very thorough. I had a question about iron deficiency and the targets for iron therapy.
So iron deficiency and like risk of deficiency in heart failure and what we should target for replacement. Is that right?
Yeah, yeah.
I really wish I had specific answers on that. I will say it wasn't a big part of the what I was looking at when I was doing a literature review, but the brief mentions of iron deficiency that I saw, I don't know that there are conclusive targets that we should be sort of holding on to in order to reduce the risk or sort of also modify risk in patients with existing heart failure. But I wondered if Ben or Nisha know differently.
So there are clinical trials in the heart failure population that in which they're giving IV iron, and there's thought to be the effect on anemia, but also an anti-inflammatory effect is thought to be cardioprotective for prevalent heart failure patients to reduce the risk of heart failure rehospitalization and mortality. We don't know in dialysis patients, it's tricky. We know anemia is bad. How to correct anemia has been tricky in our field. And so I think there's some work to be done here. And this, even with the newer anemia treating agents, right? The HIF pathways and other things. So I think we'll learn a lot. But I agree with you, Mahlet. There's not much we know yet.
Thank you.
Mahlet, maybe you can disabuse me of a conceptual model that I probably held on too long, but I tend to want to separate people that have just volume overload in ESKD versus heart, these many other overlapping kind of vascular contributors to heart failure. Do you think that's helpful? Or maybe it is ultimately a spectrum, but I wonder about if, some of those groups respond to volume management or different modalities because of kind of different contributors or etiologies. I don't know if you have any thoughts on that.
Yeah, no, that's a really good thought. I think it's I know that there are people who have very strong opinions in one direction or the other in this group. Some might say all heart failure is just kidney disease or the other way around and so on. But I think the tricky part there is, right, if there are patients with ESKD who don't necessarily have manifestations of left ventricular hypertrophy, at least on echo, right? And so volume for them, is an issue in the context of their kidney disease and the kidney failure. But the issue becomes that a lot of our patients, although the guidelines say that within 3 months of folks, having been started on dialysis, I think part of the guideline recommendations to obtain echoes for folks. But a lot of these patients don't necessarily have echoes, but likely, the percentage of folks with the prevalence of left ventricular hypertrophy and ESKD is 75 to 90%. So there are a lot of the folks have some degree of diastology. And so how much of their volume overload is, their diastolic dysfunction versus their end-stage kidney disease is hard to say. And then in terms of thinking about how much of an impact does focusing on volume overload make in patients with diastology versus with HFrEF, essentially, I don't know that there are specific thoughts about that. Recommendations.
Probably figure these things out if we're going to get echoes on all these patients and know how to treat it. Well, if there's one last question from Mahlet, we could take it. Otherwise, we should probably move on. But thank you so much for that talk.